Swinging the twig.
I
No, twig is hard. Swinging the stick.
Dude, whatever it is,
Keep doing it.
yeah, keep doing it. Don't change things.
But I went the next day. I was hitting far. It was nowhere near like, but I was like also top. I don't like being in the top. Like the top. It was like packed downstairs. But like I don't swing to my potential because I think I'm gonna fall off.
Yeah.
So like I don't know. It was all off. I couldn't follow the ball.
That 8-iron breaking through a heartbreaker, man.
Yeah, you know, I got it anyway.
You can get it, dude. Get it reshafted at like
Well, this is sucks.
Dick's 40 goes your golf.
Yeah.
I was like, what a day to not have to go.
Man, those are 300 plus every damn time.
That was ridiculous.
Yeah, it was crazy. I never done it.
Like, I don't know.
Yeah.
I don't know, dude. Like, where did that come from?
I don't know. I hit. That's when I hit straight, you know. With my irons, I'm straight every time. The driver, like I said, I've always had an issue with it. But dude, something happened.
The way I looked at it was like,
Dude, I was hitting probably 340 almost every time.
That was probably
If that fence was really 300, I was hitting the mid fence like every time.
You hit the 300 plus something.
like we were in like
Yeah.
6 quizzes in at that point.
So that's probably rolling like 320,
320 inch? Yeah, that's what I was thinking. 320.
Ridiculous.
Pretty good.
That's like a Rory McIlroy.
There's no way. It was 300? And that's a legit 3?
Sure. The way I looked at it was like,
Yeah, it's crushing it all.
Dude, Rory McIlroy. What a boss. On the car. No, it was +7 through 9 holes on Friday. Shot a 70 for a pro golfer. Ridiculous. That's terrible.
It is currently
Terrible.
Alien from Alien, but
Yeah.
yeah, I can see why you think that.
Terrible.
it's like,
Very like, I think Justin Thomas was like 14.
dude,
Once I finished the head, I was like, yeah, I'm gonna
I
go
almost
for that.
rolled my ankle and completely destroyed it. I felt that. That was not
Good
good.
catch.
I was like,
ATF
down?
almost.
Who's down?
It was bad. It was like,
I roll my ankle.
I know like the more contact.
that one would have been bad though.
Yeah.
I felt that.
There? That would have been fun.
All right, everyone prepare me.
That might have been an ice pack for Rashko over there.
Might have been some Russian. Eventually.
What is this? Go down. Come on.
Well, he said no all of them, like, I mean, like, from like C4.
I love the ABCs. Look, do you want me to do the capital or lowercase?
I know that.
Oh,
Person?
Tell the red lady to write me a paragraph.
You write me a letter.
It's just,
do my hands.
Cold.
My fingers are
See, I'm really, am I warm?
You're warm, yeah. I'm always cold. I'm frozen.
C4, 5, 6.
Are you cyanotic yet?
Yeah, pretty much.
Yeah. Always warm.
Well, yeah, you start going into like, if we're talking about what else.
Sure, yeah, good.
So like when I'm doing like certain things on Dan, it's like total
Yeah.
stuff because my hands are so small. You know, look like patients.
Dude, my sister had Raynaud's, and we didn't know this.
I mean, way.
Until like maybe like 3 years into me playing hockey, we were just like sitting on the rink. Like my sister's hands just shot this. It like clammed up and cramped. So she like couldn't even put her hands. So basically I just shoved this poor girl in a hockey rink for like 15 years. And
Oh my
she has
God.
circulatory problems.
It's funny, you can see it on Professor Denarco's hands. Yeah, you can see it, like he's got like a discolor.
When it's cold out, it's literally like his fingers are really
Yeah.
Because like picks at his skin a lot. They're really
Oh,
shy.
yeah. Yeah, we only really have, like, we don't know him that much, you know.
I'm really shivering. I'm so
You're cold.
I'm gonna put my jacket on.
My go-to little lock spread, tomato,
It's a little chilly in here.
dying,
During
tomato, I'll
orientation,
take it.
I couldn't focus. I was like literally like,
Yeah, it was freezing.
the whole
Oh
time.
yeah,
It was down chill day.
like 7 feet.
Yeah, remember? It was freezing.
I'm like, how did I not? I'm like, I put the sweater. Even if it's
Yeah, man,
95 degrees outside, I
had
put the
this
sweater
thing
in my bag in my car. It's cold.
Insane. Be prepared.
Stop spending money today.
Exactly.
Nice spot.
Exactly.
Yeah.
And then my ass was ordering custom, ripping it down. Ice by the time you get back.
You could eat your own.
I know, I'm salty about it. It's a heartbreaker. Oh man. What'd you do over the weekend?
Video when they were trying to I'm in there, like, no, my brother came up from North Carolina, chilling.
It's like you're not really doing
Chris,
your job.
who's your CI in the hospital?
At this point.
Chris for both of us?
No, who's your actual PT? Kevin? Alright, I got this little Filipino lady.
Oh, it's my place.
Carol.
They moved
Dude,
locations.
she,
This like the.
You start this week?
Claire. Dude, a talk show.
Thursday, Friday?
I had to know everything she was saying. I was like,
It's just so busy.
She asked me a lot of
It's so bigger. They like doubled their space.
yeah, it's doing like,
That's nice.
like a lot of assists with her.
It looks like they're happy they want us there. They're like putting us to work.
Yeah, it's for real, man.
Get in here.
Yeah, you gotta help rich people right out of bed. Saturday, they had a
It's
patient.
easy, just know the couple and push the button.
Dude, it's amazing.
It's great.
It's amazing.
Yes.
The first patient I worked with, dude, the first patient I worked with had no right knee and like no second and third toe. It was partial weight damage to the heel, so it's like sat him up, like how much you
I don't think they want us
Even
to
the,
work with the same guy. He probably pissed off us dudes, like, oh, I gotta, you know what I mean? Like,
my buddy's CI was,
what a spread it is.
my buddy's CI was Kevin, and the other guy's CI was Steve Ryan.
Matt, that's right. Yeah, they're all pretty cool. They're all nice.
Yeah, no, it's just kind of like chill and go to work.
even though the hospital seems super intimidating, you learn so much there. It's like, it all makes sense. You work with so many people, you're like, I can't work with anyone. You learn patients, you're like, alright, maybe like someone you just wanna walk up and down the hall. You need to work with someone who's got like, I think some people are like, I can do anything now, I can conquer the world. A lot of times it's actually from like the onset, like what they're there for. So let's say like when they have an orthopedic surgery
Dude, my minimal interaction with him is fine.
or back,
I just need to see him in the morning,
they'll
say
see
what's
them
good,
like
and keep it moving.
right after.
I don't know if
Sometimes
that guy.
they'll bring them from the OR upstairs to their room. Their PT will literally be them getting out of the stretcher and walking in the room. Like right at it, because you want to maximize the time you have with anesthesia. You don't want to walk in the chest pressure's really low or
I
like
would give them a little bit of a
you're
more
on
like,
your ass anesthesia. But that's an like if you're somebody who's in like
I want to learn, but I'm blind.
good. See how you feel, then get you up, walk down the hall. Stairs, we get a lot of discharges, so it's like, they have to do stairs to be able to get them. If they have steps in their house, they have to be able to do stairs to be independent to go home. Or use recess, and they say, alright, are you gonna rehab? So,
We just referred everybody to subacute rehab. Like, everybody's charts all day was, please refer out to subacute rehab.
I was just telling him, like, you learn so much from
So what's the subacute rehab?
They take them out to the hospital.
They take them out to the hospital, they take them home, like, they stay there for a little bit, and then they go home.
Yeah. I mean, some we were immediately referred for home care.
Yeah, some are home care, some are going home, they'll just like keep you sent to
I had a
them.
guy sitting out there, he was sitting there like, you sit down.
I've seen some pretty wild.
Yeah.
On Saturday, or the week before, there was a patient who was on the screens, and he had two security guards sitting out of his room. One inside, and one outside his room.
Read and reread, because I did your test, then I'll come back to you. Highest, there were 4 90s, highest grade in the class was a 98, and that was Ashka.
Ooh, let's go.
Yeah, you did terrible, huh?
Terrible dog shit.
When I do these tests, I'm liberal, because I try to see if you have an understanding, and I don't expect you to be perfect, but I do expect you to understand it and be able to explain it. But of course, if you don't write anything, it's a 0 on that question, or if you just give me a whole bunch of junk that hasn't applied to the question at all, it's a 0.
Which junk did I give you?
Some junk, I don't know. But anyway, I'll give it back to you after class.
Dog shit.
And I encourage you to reach out to Kevin, those of you who haven't. I encourage you also to reread the chapters, because and my understanding is some people don't even have the book, which is absolutely ridiculous, because how would you, I mean, even if you sat here and if you listened and you paid attention and you looked at the PowerPoint, you would probably understand it, but, a lot of you turn it off and then say, I'll look at it later, and then don't learn it. So you really need to read it, and especially with nowadays, there's so much on the internet. If you don't understand it, you could always look it up. But there are some, I just don't understand why some people have no understanding. And if you don't, then, there's a problem. So you need to contact somebody, whether you contact me, whether you contact Kevin, whether you come to open labs. They're available, and tutoring is available. So, and this is something you have to know. You have to pass the state board exam. They ask you questions about modalities, like it or not. And you also should know what you're doing when you're out there treating. So, having said that, and again, I will give you the exams, the test after, if you have any questions, and we could discuss. If you feel something wasn't fair, we could discuss. I tried to find the good in every question. So, but if you can't answer anything about temperatures, right? So let me see. I have somebody who I think. Isaiah, where are you? Isaiah, what are the temperatures you would use for a whirlpool for pain? Do you think you got that right? Do you think you got that question right? I think I remember you getting that question wrong. That's why I'm asking you. There was other people that got the question wrong, right? Because they wrote nothing? Okay. So what my question to you is, did you look it up when you left? Okay. Did you look it up? So do you remember, Isaiah, for pain management, what the range is? I'm just putting you on the spot. I can put somebody else on the spot. Devin?
I think I said 1. I said 99 to 104.
Yeah, 99 and 104.
So,
Yeah.
did that like warm range or hot
Well, you can't
range?
just write warm.
I think I gave you temperatures. I think I gave you a bunch of temperatures.
All right. Well, if you did, then you should remember them, right, Devin?
I guess so.
Okay.
It was a long
All
weekend.
right. But you can't forget, because those kind of questions are going to show up. They're going to ask you a question about temperature. They're going to ask you a question about what has the, I think pretty much most of you got this right, what has the most, what do you have to consider most when you're thinking about depth of penetration with ultrasound? Frequency, right? Frequency, and it's the difference between 3 megahertz and 1 megahertz. And for goodness sakes, Golgi tendon, muscle, spindle. I think there was only one person, I think it was you, that got 5 on the Golgi tendon, muscle, spindle question. But most people just said, oh, it's in a muscle. Oh, it's somewhere near a muscle. It has to do with some protection. Yeah, how about active contraction as opposed to passive contraction? How about the fact that it's in line with the muscle fibers? How about it fires, they're both passive, they both fire in response to protection of either the tendon or the muscle. How about facilitation of the agonist, inhibition of the antagonist, right? Those kind of things. That's what I expected you to write. And wounds. But we went over wounds. The difference between a venous and an arterial and neuropathic wound. Not just one's lateral, one's medial. Because that doesn't mean anything. You could have a medial, you could have a lateral and medial wound, and you could have a lateral and 2 lateral wounds, and you could have nothing over the medial malleolus and still have a venous problem. So, I mean, you have to describe which ones do you compress, which ones do you elevate, which ones drain, which ones don't, which ones are painful. Where's the location? What's it from? Gate theory, I think you guys are okay, sort of, pretty much on. But again, you just have to review it. All right, so I think I wrote some things on some papers, but then I got to the point where I wasn't gonna write all the answers. What are the cardinal signs of inflammation? Didn't I say you need to know that? Cardinal signs of inflammation. So some people just said, well, it gets kinda warm. That's not a cardinal sign of inflammation, right? Because there's a lot of things that get warm doesn't mean that you have an inflammation. So you really have to know this stuff. All right. So did you reread it? Yes? No?
I'm sick.
Yes.
So what do we know about electrical stimulation? What do we know? What do we know the differences between something that's, oh, I know the other thing. The other thing is, no, I'll tell you individually. Yes,
I was looking at, this slide right here.
yes.
What is the difference between symmetric and balanced asymmetric?
Okay, that there's no charge associated with either one. He's asking the symmetric and the balanced asymmetric. There's no charge associated with either one. If that looked like this, then, see, there's equal charge here, so it negates itself, so there's no
Yeah,
charge.
what does that, like, triangle graph?
That's just a different, it's not, it's balanced, the charge is balanced, but it's not symmetrical to this. It doesn't look exactly like this.
Would the amplitude be different or?
No. That just means that you have, and you very rarely see this, but that just means that you have the same amount of, you have a positive charge here, a negative charge, and there's no net charge accumulation because they cancel themselves out because there's the same amount of charge here. That's all. Okay, so let's talk about electricity. And what's impedance? Impedance. Resistance to flow, right? Resistance to circuit to electrical flow. And what can give you some impedance? Yeah. Skin,
Moisture.
moisture, hair,
A lack of moisture or too much moisture?
too much moisture,
Lotions can cause lotion on skin.
Motion.
cream, lotion, right? All that kind of stuff. All right, we kind of talked about a lot of this stuff. We talked about positive and negative. We talked about, what's this? What is this? Anybody? What is that? What is that? Strength duration curve, right? Wasn't that one of the questions that you had? And you didn't even have to do this. You could have said to me what you did in class, and what does the strength duration curve tell you? It looks at the amplitude and looks at the pulse duration, and it tells you how much of a current and how long the current needs to be on to elicit things like a sensory, a motor, and a nociceptive response. So some of you wrote things like, you put the stim on, and the first thing that you feel something, and then you get a contraction, and then it hurts. Yeah, I gave you points for that because that's exactly what this strength duration curve tells you, right? So which has the lowest threshold to fire? A sensory nerve, followed by a motor nerve, followed by a nociceptor. And so what do we know about all this? What did we learn from this? We learned that the more that you have the current on, the longer time or the pulse duration, the greater that you can elicit other fibers besides sensation, right? Because you put the current on, you felt a little tingling. Then you started to feel, then you got maybe this, and then you got this, and then you said, ow, it hurts, right? So when we talk about sensory, motor, and nociceptive input and the stimulation of these nerve fibers associated with that, it all depends on the amplitude as well as the duration. Yes?
I'm a little confused with like tens and like just like I know tens is a form of E-stim, but a lot of times it's like combined that you can a tens machine is the actual E-stim machine. We're using a different machine, so how do you?
10 stands for electrical nerve neurostimulation, right? So, transcutaneous electrical nerve stimulation, that's what it stands for. A TENS unit is a small battery-operated unit that's only used specifically for pain. That's it. It's not used to elicit, to do muscle re-education, to help with edema. It's not used for any of that. It's just used for pain. However, all of the units that we use are known as TENS. I shouldn't say TENS units, but they're TENS machines because they all work on electrical output to elicit responses. Okay? But a TENS unit is just a little battery-operated TENS unit is just used for pain. Okay? Because you can't really adjust the parameters like you can with the other machines. And we did it interferential the other day too, right? We felt that interferential was comfortable and we saw that there was a sweep and there was a scan. What does the sweep setting do?
Prevents accommodation.
Well, yeah, because we get adaptability and then we get accommodation from the nerve, right? But what does the sweep setting do? Sweep. Yeah, it kind of goes like that, but what does it do? Anybody remember?
Steadily increases the heat.
Andrew?
Change the frequency.
Okay, so it changes the frequency. So if the frequency is set from 80 to 150, it goes from 80 to 150 and then back down to 80, and it takes 15 seconds to do that. There is also in those units a scan button. And what the scan does is it modulates the amplitude. Okay, so what does that do?
Is it the same thing?
Does the same thing. It helps with accommodation, right? Anytime you modulate a current, it helps you to prevent from getting used to it. Yeah? Okay. Yes, Dave? Okay. Yeah. Uh-huh.
So for acute pain, we want a high frequency and we're stimulating the A beta fibers. For the chronic, are we also, what's being stimulated there? I know we want a low frequency and a high duration, but what are we actually stimulating?
It's a release. It's a top-down effect, a release from the brain, natural endogenous opiates. So it causes a release. Opiopeptides, which are your serotonins, are released from the brain by getting them. This is the theory. Okay, they've done studies to see that this is what's happening, but you need a motor response for that. So high frequency, low duration is used for what?
Acute pain.
Acute pain. So high frequency, like 120 cycles per second, low duration, 60 microseconds, something like that. And a low frequency, 0 to 10, and a high pulse duration, depending on is it an upper extremity or lower extremity, microseconds. We're dealing with 150 to 250 or 250 to 350. You want to elicit a motor response for serotonin release.
So there's a motor nerves that
Correct. So we're going to talk about, what did we say about electrodes? What do we say about current density? Where is it greatest? Where's current density greatest? Brian?
Current density is greatest superficially.
Devin?
I don't remember.
What'd you guys do this weekend? Andre? Thank you. Yes. It depends whether you use a small pad or a large pad, right? So is it greatest under the smaller pad or the larger pad? Smaller pad. So what does that mean? It's also greatest where the electrode touches the skin. Okay, so where the electrode meets the skin, current density is highest. But it's also highest under the smaller electrode. So what does that mean to you? Why do we have to know that? because I like you to memorize things?
You know, the pad placement has to be specific. Specificity for pad placement. Like you need to know like where you're gonna put it and like the location of the pad.
Does that have to do with whether it's small or large?
Well, no, it could increase that intensity or decrease that intensity based off of placement or just how the patient feels it.
You have to know how superficial the structures are underneath the skin.
Does it have anything to do with superficial?
Well, yeah.
Why is it important to know that current density is greatest under the smaller electrode? How does that affect how we treat a patient? What if you turn the amplitude up and the patient said it's uncomfortable? What would you do, Dave?
Depends how much the patient.
So he's saying, Kyle, what are you saying?
Yeah. I think I was saying it too low.
What are you
Depends how
saying?
much the patient can tolerate. So like if you depends
Power?
how much the patient can tolerate like the feeling. So like if the smaller one's greater, if it's too much for them, you would give them a bigger pad.
So let me get this right. What you're saying is if a patient complains that he can't tolerate the current, you can increase the size of the electrode.
Yes.
Is that what you're saying?
Yes.
You're absolutely right. You're absolutely right. That is always a state board question.
Always.
Okay? Because it's about comfort, it's about burning, right? It's the same thing like you guys say, oh, I like those sticky electrodes that I use on 12 different patients and I don't use the same one on people. And then they don't stick. So you got an electrode this big and now the outsides of the electrode don't stick to somebody anymore, just the middle of it does. What have you just done? Increase current density. What else have you just done? Increase the possibility of the patient get a burn. Okay? Because what do you need? You need some kind of a medium between the electrode and the patient themselves to prevent a burn. Right? So now, patient has a burn, increase current density, which means what do you have to do to the amplitude in order to get enough current? Increase it. Right? Which makes it more uncomfortable. So, all right. So we talked about current density, we talked about the size of the electrodes, and we talked about the fact that if they were closer together or further apart, what would happen? So if they're closer together, what happens? Monica, if you have electrodes that are closer together, what happens? Dave?
Only feel it superficially.
You'll only feel it superficially, yes. What happens if they're further apart?
You go deeper.
The penetration is deeper, right? Yeah. If we wanted to elicit a response in a denervated muscle, Rod Neal, what would we have to think about? What? If we wanted to elicit a response in a denervated muscle, what would we have to consider?
Strength, duration, current.
The type of current.
AC or DC?
How much you have to,
It's a type.
amplitude or intensity, how much you have to turn it on? Anybody else? Andre? Consider the type of current
DC
you want
current.
to use. You'd want to use direct current. Yes, what else? Dispersive pad? Okay, what else? Marissa? Yes, yes, you'd have to increase the pulse duration, you have to have something that has a pulse duration of milliseconds as opposed to microseconds, because you can't depolarize a denervated muscle there's no nerve, right? The nerve's not working, so we need a more aggressive impulsoration. Yes, all right, so I've got a couple people that are reading. All right, and stimulation points. What points would you stimulate? What points do you think you'd want to stimulate to get a muscle to contract?
So you said from microseconds and milliseconds, right?
Milliseconds. What points?
Motor points.
Motor points. Motor points or trigger points, right? What's a motor point? Where is it usually found? In the muscle belly, and it's usually closest to the skin, right? It's easiest to react. Good. Good. All right. Thermal density, electrode placement, stimulation points, tissue excitation. Did we go over this?
No.
No. Stimulation parameters. All right.
Professor, so those are motor points. Can you just, in terms of trigger points, those can they be not anywhere near the muscle that you're trying to activate? Or are they usually, is a motor point and a trigger point, are they different?
Yes.
Or a lot of times
Yes, a trigger point is just a taut band in a muscle that usually refers to other places. So it's a tightness. When you press on a trigger point for about 30 to 60 seconds, you may elicit a lot of pain in that area or pain in a referred pain pattern, but it's really the patient will jump, ow. It's a trigger point. It's a taut band. And a lot of people have trigger points in their upper traps and motor points in their upper traps. Remember we went over them, and when we did E-stim, patient went, oh, I really feel that. So if you have tightness in the upper trap, which most people do, as well as the fact that the upper trap is more superficial and the motor point is in the middle. Okay, so pulse rise time is the time it takes for the pulse to rise. You don't have to worry about. The amplitude is the intensity. So the strength of the current, right? The magnitude of the charge. A rapid rise will cause nerve depolarization. I don't know where I am here. Slow rise causes nerve to accommodate. So remember we said accommodation will, it's good for muscle re-education because you don't want to turn the current on right away because then the person gets shocked into. So you want them to gradually get to start to contract their muscles, because when we contract our muscle, we don't elicit all the motor units at once. We elicit what we need, right? So it's good to have a rise time. And a rise time of comfort is generally 2 to 3 seconds. All right, let's see. Good for muscle re-education. Okay, and when we do muscle re-education, we ask the patient to work with the machine, right? Electric stim is not the same as volitionally contracting your muscle, but we'll talk about that in a second, because when we contract the muscle, we recruit both slow and fast twitch fibers. Yes?
Quick back to the rise time. Is there ever a situation where you would have a shorter rise time? And why?
No, not really. Not if you're going to do muscle re-education. If you're going to do just E-stim, just for muscle spasm, I really wouldn't use a rise time, because I want to bombard that muscle with stim.
May I have your attention, please?
But if I want to
The
know,
oncologist coronavirus task force needs everyone's full cooperation and adherence to the CDC's COVID-19 guidelines when you are in the building. Everyone must wear a face mask at all times in public areas of the building. Everyone should observe social distancing, which is 6 feet apart. There should be no more than 2 people on an elevator at any one time.
he did better.
Everyone should wash their hands frequently.
I
If
knew
you
I didn't
feel
do that.
ill, please stay
He did
home.
better. He
Thank you
passed.
for your
I
cooperation.
told you I passed it. You asked me a couple times. I passed. I told you I passed.
That's terrible.
Huh?
You're like, I told you I passed.
Yeah.
And I didn't do so.
See the respect I get? See the respect? Okay. So slow rise time, good for muscle re-education. All right. So any amplitude that's less than 150 volts is known as low voltage, and this only refers to a specific current that we're going to use that's known as high volt pulse galvanic, it's not high volt,
No, high voltage.
HVPC, high volt pulse current. It's also used interchangeably with high volt pulse galvanic current, but they don't use that term so much anymore. So high volt pulse current. 150 volts or greater. 100 is high volt. Anything that's less than 150 volts is termed low volt. And then we also have TENS, transcutaneous electrical nerve stimulation, neuromuscular electrical stimulation, microcurrents, and iontophoresis. Iontophoresis is a DC current. Okay, iontophoresis is also used for delivery of medication, right? The transdermal delivery of medication via an electrical current, as opposed to the question on your last test, transdermal delivery of medication using ultrasound, and that's phonophoresis. Okay? So when we talk about different types of medication, probably the only ones you'll need to know the polarity for are dexamethasone, which is a anti-inflammatory, that's a negative polarity, and lidocaine is for pain, and that's a positive polarity. But we will go over a lot of different medications, yes.
So for high volt, would you use negative polarity? Like, that's when you use
High volt, yeah, we haven't talked about it specifically, it's a twin peak monophasic waveform, but high volt, it's kind of like, it's kind of like, I'm sure you've all done this. You've had a candle, when you were kids, there was a candle, and you put your fingers through the candle, right? I'm sure you've all done that. Is there anybody who has never done that? Put your fingers through the candle flame? No? Yeah, you've all done that. Did you get burned? No. Because the duration was so quick, right? Very short amount of time. And there wasn't a lot of current. Not a current, a lot of fire, because you just went like this. It wasn't like you were at the bottom of the flame and you just went through the top. So the intensity was different, yes? Okay. But the time was really quick. That's kind of like how high volt operates. We have this twin peak monophasic waveform, and that is what we have to, what your initial question was about. I'm sorry, I went off on a
It
tangent.
was just about, like the polarity.
Oh, the polarity. So if you're, and we really will talk about that in 1 second, but high volt is used, as a rule, positive for pain, negative for edema, right? However, you have to know if we're going to be doing wound care and you have an inflammation as well as an infected wound, infected or inflamed wound, you use a negative polarity because of what would be attracted to the electrode to help with the inflammation as well as the necrosis. And a positive polarity for a wound without inflammation and without infection. Okay? So as a rule, that's what you use. Positive for a wound that's not inflamed or infected, negative for a wound that's inflamed and infected. Okay?
Still DC current for both of those, correct?
And I told you last time that edema has a negative polarity, so what would you use, what electrode would you use on that? A negative, right? So is that a cathode or an anode? Cathode, right? Okay, so you use a negative electrode on a negative for a negative problem because you would move the edema away from the electrode.
So, like, let's say if you had edema somewhere, where would you place
Okay.
the electrode?
With a high volt machine, either you can take an electrode and you could place it in the wound itself. But what would you have to do? You would have to take the electrode, you would have to, you would take the sponge out, you wouldn't want to use a sponge, you would want to use a paper towel, you want to make sure it's wet. You'd place that wet, and you'd also wrap the electrode with gauze and saline. You would stick that electrode right in the wound. And then so when you removed it, you'd remove all the debris that would be on the electrode. Okay. Or you can get there are electrodes out there that you can just put it, that you could purchase and just put in and get rid of. Okay? But you could also put an electrode above or below the wound,
That's
right?
what I was thinking.
Yeah, you could put the electrode above or below the wound. But you could also put it right in the wound.
Okay.
Right in, huh?
Okay? All right. And we talked about, this question was on the test the other day because we talked about it in lab a lot. And we said, what was the difference between twitch and tetany? And we said twitch was this little jerky reaction that was like this, right? And that was based on frequency, yes? So 0 to 20 or about 20 pulses per second. So the frequency or a rate of 20 would give you a twitch response, and tetany would, in order to get tetany, you would have to use 35 to 50 pulses per second. Yes? So a frequency of 35 to 50 would give you tetany. Okay. So here it says tetany is a function of the frequency of the current. That's important. Frequency. So you need a rate of at least 35 to 50 and not the intensity. Okay. You guys saw that. All right. With continuous AC current, and I said AC current, there's no net charge buildup, right? AC current. If frequency is greater than 35 hertz, tetany will occur. If you keep increasing the frequency to 80 and above, you'll still get tetany, but you'll get muscle fatigue. Okay? Denervated muscles take a lot longer to be stimulated, so what do we have to do? It only responds to a DC current, so we need to change the current, and we need to change the pulse duration that we're able to change when we have a DC current to at least greater than 10 milliseconds. All right. And finally, a DC current iontophoresis. We have chemical effects under both electrodes, the cathode as well as the anode. It's good for wound healing. High volt pulse DC currents. And when we do iontophoresis, we do treatment in milliamp minutes. So 40 milliamp minute treatment. All right, so if we do 40 milliamp minute treatments and we have the intensity on at 1 milliamp, how much time would it take to deliver the medication? 40 minutes. If we're delivering an intensity of 2 milliamps and we want a 40 milliamp minute treatment, how much time would it take to deliver that current and that medication? 20 minutes. Everybody get that? All right. All right. Oh. Adaptation. For some reason, I won't pull my notes here. Adaptations, the patient will get used to the treatment, so they'll adapt to it. So in order for them to adapt to it, and when they adapt to it, you get nerve accommodation. So when they adapt to it, what do we need to do? We need to modulate it. So what happens is that the brain recognizes this as normal after a period of time. That's habituation, this repetitive information. Accommodation occurs with the nerve itself. Okay, so the nerve will accommodate as the person adapts to the current. How do we prevent it? We can modulate. We change the current. So either we can modulate the frequency, modulate the amplitude, modulate the intensity, modulate all three. Okay, change the way the current comes out. We could burst it so that it comes out very rapidly within a very short period of time. So anything that we can do to change the current flow will help prevent adaptability and accommodation. All right, so these are ways we could do it. Pulse it, surge it, that's an old term. Slow rise time and a slow descent. It's an old term for modulation, and it modulates both the amplitude and the frequency. The sweep and scan, I told you with an interferential, we could sweep the frequency, or we could scan the intensity. All right? So don't get messed up on the words. Intensity is the amplitude, is the dial you turn up, that's the intensity of the current. And then frequency is the range of the pulses per second, or the rates. And finally, ramp will adjust how long it takes to build up the current and how long it takes to come down. So that's the ability to start contracting. You can get the person to hold and relax and then to release it, okay? Because as I said, as we start, if I went to pick up something, these keys here, I know how much they weigh, so I know there's some motor units that are being recruited to pick this up. But if I had to pick this up, there's much more motor units that are recruited in my arm to pick this up. With electrical stimulation, it's all or none, right? Electric stimulation does not selectively choose motor units. It just makes them contract. So it's not the same as a volitional contraction. That's why we add volitional contraction. Yes?
So intensity is amplitude, and that's voltage.
It depends. Are we using high volt or are we using amps?
Well, that's what I was gonna ask you. Voltage and amps seem both to be a part of intensity.
Yes, they are.
So which is,
It depends what machine you're using. If you're using a high volt machine, you're talking about voltage. If you're using a stim machine, you're talking about milliamps.
so you're not,
That's all.
and these can't be adjusted on the machine.
The intensity? Sure, you turn it up.
That's adjusting
Yeah.
voltage on a high
Yeah.
intensity machine. On a low one, for
You're-
tens units amps.
Right,
Okay.
right. Okay, so current modulations, you could see that this modulates the amplitude. So you set it at number 12, Chris, right? Because you started feeling it at number 12, or you got a contraction at you know what I'm talking about when you look at the machine and
Yes.
you have to turn it up, turn it up, turn it up. You set it at number 12. Well, here, it's going to go from 1 to 12 and back to 1 again. So that's going to make it not consistent, right? It's going to make it,
That's the ramp time.
that's the amplitude. It's
So
modulating,
That's scan then? That's scan.
yes,
Okay. Sweep is for.
frequency,
Is for frequency, scan is for amplitude.
yes, yes. But again, you need to sit there with the machine and play with it, because that's the only way that you're going to remember it. All right? Frequency modulation is going to change the frequency, right? So you see from this picture, right? So it modulates the frequency. And duration is going to modulate how long or how much current is flowing through that in that given time.
I'm writing your PowerPoint. I'm not looking at anything else. I'm taking notes.
There's Devin. Okay, so what do we do for muscle contractions? What do you think we need for a muscle contraction? What do we need for a muscle contraction?
35 to 50 hertz.
35 to 50 hertz. Why?
Because it's going to produce tetany without fatigue.
Because that's going to give you tetany without fatigue. You good on this? You've heard it enough, right? Think you have a 50 question exam next Wednesday?
What?
50 question exam next Wednesday?
Not this Wednesday, next Wednesday.
Yeah, next
9
Wednesday.
days from now.
Yeah.
I don't
What
want
do
to
you
hear
think?
Yeah, we got it.
I think so. To give you time to make yourselves look better in my eyes. All right, so look at these two, look at this slide. Motor level stim, comparison of voluntary or volitional contraction versus electrically induced contraction. Look at voluntary. Type 1 fibers are recruited first. Type 1 fibers are slow twitch fibers. Asynchronous. What does that mean? What did we just talk about? That they're not recruited at the same time, right? I don't need all of those fibers to be recruited to do this, but I'll need much more if I want to lift this. Yes? and the GTO is protective. What does the GTO do? Facilitates what? Antagonist,
Responds to contraction.
active contraction, facilitates the antagonist, and what else does it do?
Inhibits the
Stimulates or facilitates the antagonist, and what does it do? Inhibits the agonist. Okay. Now, if we look at the other side, also, with a voluntary contraction, it's smooth, isn't it? Isn't it smooth? I mean, your arm never goes like this, but yet, with an electrically induced contraction, it can look kind of jerky, but this is a nice, smooth, sustained contraction. With E-stim, type 2 fibers are recruited first. Type 1 fibers do become recruited, but initially, type 2 fibers are recruited first. And type 2 fibers are fast twitch fibers, and what do we know about fast twitch fibers? They fatigue quicker. All right? They fatigue quicker. Hence, the amount of contractions that you want when you place somebody on for muscle re-education. Right? Because if you place them on for a long time and maybe 40 minutes and you're looking for 50 different contractions, plus you have a duty cycle that's 10 on, 10 off, what's going to happen to the muscle? You're going to fatigue it. You guys sleeping,
And it won't.
you're going to
it won't give
fatigue
you
it.
time to repolarize.
Yeah, you're not going to be able to depolarize. You're going to fatigue the muscle. Muscle's going to be sore. Have any of you sore when you went home after you set the machine up and left it on constantly? Yeah. Yeah. You're going to be sore. Is that something you want for a patient?
Especially when it was spiking intensity.
No. All right. So, type 2 fibers will fatigue and they'll atrophy quicker than type 1 fibers. And then GTOs don't limit the contraction, so you don't have any protective mechanism in place, as you would with a volitional contraction. Right? Okay. So motor level stimulation. The amplitude, we want enough amplitude for the contraction to occur. Phase duration, we're going to use 150 to 300. What did we say? Like 150 to 2 or 150 to 250 for smaller muscles like the upper extremity, and 250 to 350 for the larger muscles like the lower extremity. Okay, that'll target motor nerves. The shorter the phase duration, the more amplitude is required, right? Makes sense? Phase duration. Longer durations will depolarize pain nerves too. So the longer the duration, the more nociceptive input you'll be getting. And pain will often limit the quantity and the quality of the contraction. Pulse frequency will determine the type of contraction. Right? So we'll get a twitch response with 10 to 20 pulses per second, and we'll get tetany with 35 to 50. Anything over 50 will still get tetany, but we'll get muscle fatigue. Okay? All right. All right. So, as the frequency will increase, you get a muscle contraction. We've done this ad infinitum. A lower pulse per second allows a longer interpulse interval. So a low pulse is anything below 15 pulses per second. It's like 15, 20 pulses per second. This is from a book, but we talked about 20 pulses per second. We'll get an individual contraction. We'll get a summation, the contractions will start to blend, and then anything over 50, we get a constant contraction. And you saw this, so a lower frequency will give you a slower twitch. As you increase the frequency, it gets faster, and then finally it gets to a sustained contraction. That's all based on the frequency of the current. Okay? And it varies from person to person. So that twitch, that summation as they start to blend together, and then finally, so you get a single little twitch, then they start to blend together, and then you get a muscle contraction, sustained contraction. All right, pain control. So, target tissue, sensory. What does it say here? Phase duration, pulse frequency, intensity. What does that mean to you? Isn't this what we said last week and we're saying it this morning too? Sensory level. What are we stimulating when we turn the machine on? We ask the patient to tell us when you feel it. All right, you're actually stimulating A beta fibers. What do A beta fibers do?
They close the gate.
A beta fibers, it's mechanoreceptors which send information from the periphery to the spinal cord, and they, according to Melzack-Wall's theory, close the gate and prevent nociceptive input from going to the brain, right? What do we need in order to do that, or to make these nerves fire? What parameters do we use to make these nerves fire? We use a high rate and a low pulse duration, okay? So here it's just showing you a pulse frequency of like 80 to 120 pulses per second. But what should the patient feel? Or what should you see? What should you tell the patient? Should you tell the patient you want this to lift up your muscle and move it? No. You should say to the person, tell me when you feel it. Tell me when you feel it. We're not looking for a contraction. Okay? So it's a high rate and a low pulse duration. The pulse duration is probably around 60 to 80 microseconds. You don't have to memorize that. Just remember that it's a low duration. To stimulate motor nerves for that top-down natural endogenous opiate release from the brain, which would be our endorphins, we need a phase duration. So you see the phase duration, oh, I didn't see it up there. It was less than 60 microseconds, so 60 microseconds. Phase duration of a high duration, right? A high duration, because remember when you were doing with the little TENS unit, you wanted to recruit motor units, the duration or the time to turn on had to be longer. So a greater pulse duration and a low frequency. So what do these first two things look like? Or what can we remember for these first two things? For acute pain, high rate, low width, which is the same as high frequency, low pulse duration. For chronic pain, low rate or low frequency, high width or high pulse duration. Okay? If you remember nothing, remember that. Okay? Because that's going to show up on a lot of test questions. It's going to give you all this 5 sentences of baloney on the state board, and then it's going to say this person has an acute pain problem. Which of these stim units and parameters would be best suited for this patient? So no matter what stim unit they say, it has to say whether it's high rate, low width, low rate, high width. Okay, high rate, low width is for acute problems. Low rate, high width is for chronic problems. Okay, we want to get a motor response with a chronic problem. We want to get a sensory response with an acute problem. All right? And finally, for noxious, at the noxious level, to get those A delta and C fibers to fire, we need a pulse duration in milliseconds. Okay? All right. So application of high volt or high volt pulse current. High volt pulse current. Twin peak waveform, the duration is you can't change it, the duration is in the machine. What you can do is you can change the amplitude and you can change the polarity. Okay? So this is a monophasic high twin peak where you can see twin peak. The duration you see at the top of the peak is so small. So how much current are you feeling? Very little. It can go deep. This penetrates deeper, but it dissipates as it goes through. Okay, so that's that same thing I said when you put your finger through that fire. Duration is very, very short, and the interpulse time is long. Okay? people used to use it for muscle re-education. You could still do it, but you don't see it done much anymore because it's not the most comfortable current. It's for nerve stimulation, so it's for, we could do this for edema control, pain, and mostly what you'll be seeing it done for is wound healing. Okay? Wound healing. Greater than 150 volts, high peak, low average current, so very low average current. A short pulse duration is required, right? So you can see that, and that's already in the machine, you don't adjust that. And these high peak intensities will allow for a greater stimulation more than superficial stimulation. So high volt goes into the tissue deeper, and the interpulse duration is longer, so it's more comfortable. Okay. We're going to do it for pain. It's thought to inhibit sympathetic nervous system activity. It's good for muscle pumping. It's good for vasodilation. But more specifically, we use it for wound healing. So wound healing for protein synthesis, increases circulation, bacterial cytal effect with DC currents, more so with a negative polarity. Okay, so what do we have to know about high volt, a positive and negative polarity? And I said positive and negative polarity would be positive for what?
Pain.
What kind of wounds? Wounds that are not inflamed and not infected. Negative polarity for wounds that are inflamed and infected. Negative polarity also for edema. Positive polarity for pain. Okay, so if you had a high volt machine, and we do have high volt machines in class, so feel the current. Just feel it. And it's very different. All right, so we discussed this. And same contraindications, cardiac instability, same as any other restim. Pacemakers, pregnancies, metal implants, nerve sensitivity. So if we had a monopolar technique, monopolar means one electrode, right? Or not monopolar, yeah, using one electrode as opposed to two. Bipolar using two electrodes. The monopolar, we would have one treating electrode. As I said before, if I wanted to put the electrode directly into the wound itself, I would need another electrode to complete the circuit, and that electrode would be known as what? Dispersive electrode. And the dispersive electrode needs to be what size? At least twice the size of the treating electrode, and it needs to be at least 12 inches away, right? So it needs to be somewhere out of the way. And what are you supposed to feel under the dispersive electrode? Nothing. So you have a treating electrode and dispersive electrode. Bipolar technique is when we have two electrodes. You could have them around the site. You could have them surrounding the wound or near the site. And you could also use probes. So we have probes. Very rarely do you see probes used, but we do. But you can use probes. All right. So here it says, and it also says it's not adjustable on most high volt pulse current. Electrode placement, so it's a sensory level. So it says here pain. What kind of pain do you think they're talking about with this? Look at the parameters. Look at the parameters. What kind of pain are we talking about? Acute? Did you say? Why did you say that?
Because it's sensory level, not mechanoreceptor level.
Because of what?
Sensory neuron level, not mechanical.
Anything else that let you know that?
I mean, it says on the board as far as acute positive, and then also talks about, let's see, frequency is high.
Yeah. Yeah. So generally, these things are set up in the machine, and you don't really, you can't really change them. So it's a sensory level, 60 to 100 pulses per second, less than 100 microseconds. You have it on continuous, you could have it either monopolar or bipolar. You could have a positive or a negative electrode, and you could have it directly over the wound, or you could surround the wound. All right, or the area of pain. When I was growing up, meaning when I first started doing this, we didn't have biphasic and interferential and all these other things. All we had was high volt. So we used high volt for everything. We used high volt for pain, we used high volt for edema, we used high volt for wound healing. So it can be used. It's just that there's more comfortable currents. All right, so the average current through the tissues is very low because it has such a short pulse duration. So it's comfortable, but it's not as comfortable as some of these other. When we talk about interferential, we talk about there's skin resistance is inversely proportional with the frequency of the generator. So a higher frequency will offer less skin resistance. So a frequency of like 5,000 hertz or 5,000 cycles per second is going to be much more comfortable with something with a lower frequency. That's why an interferential current is so comfortable. Okay. Pain control, and this would be what kind of pain? If the other one was acute, this would be chronic, and how would we know? Because it has a low rate and a high width, or a low frequency and a high pulse duration. Okay? Same thing. Same thing. So you're getting it now. You don't have to memorize a million numbers. Right? Like I said, if you take away high rate, low width, high width, you're good. All right. Electric stimulation, edema. This is pitting edema, right? You put a finger in and it's stuck. So edema milks the body part. We used this the other day, didn't we? Didn't we do this in class the other day? What did we do to the current? How many channels did we have? Two channels. So we had a channel on, we did it for ankle sprain. Yes, so we had the channel on dorsiflexors and another channel on plantar flexors, and we were doing a milking or 10 on, 10 off. Your book states with high volt, and I mean, you can do it with 10 on, 10 off. We've done it with 10 on, 10 off. You could also do it with 2 to 5 pulses per second, if you can get it down that low, 2 to 5 pulses per second. But you can not say that you can't do it with 10 on, 10 off. You can too. You just need a duty cycle, because you need a contract relax, right? And contract relax is having that mechanical or that electrical assistance provide the fluid to be pushed back, because the venous system relies on muscle control in order to do that. Okay? And elevate the part during treatment. So edema control with inflammation. With inflammation. What do you see here? What did we just talk about? What's the polarity? Hello?
Negative.
Negative. Negative. All right? Frequency of 120, duration usually fixed, tingling. Edema control associated with lack of motion is that contract relax that we want, which is different than just edema control, right? You could agree with that? All right, so if we're doing it for lack of motion, thank you, Andrew, because I see somebody is awake. If we're doing it for lack of motion, we need tetany, 35 to 50 hertz. Okay? On-off time, we want a visible contraction. Wound healing. Either it's above the wound or it's in the wound. Okay? In any case, what is this? What is this? This is the dispersive electrode. This is a sacral wound, isn't it? Or an ischial tube wound, right? And then this is a malleoli, medial malleoli. So what kind of wound is this probably?
Venus.
Venus. Right?
Dispersal pad on the right doesn't seem to be.
Here's the dispersive here. That's the dispersive. Question?
Yeah, what about the one on the right?
This one? This one? That's dispersive. This is the one that's right in the wound itself. This is a little round one, and this is a larger round. Okay? Polarity, again, recommendations vary. Negative, early inflammation. Positive, later to facilitate epithelialization and granulation of the wound itself. Because it works with neutrophils and macrophages and protein, et cetera, okay? Yeah.
Do you mind going back to the previous slide? So for wound healing, you have the smaller pad, more proximal, but if we were talking about edema with direct current, we would want the smaller pad more distal and the dispersive pad more proximal, if it's for edema.
Well, the jury's out on whether high volt pulse galvanic is a direct current or not. We used to always call it a DC current, and now they don't call it that anymore because they pulse it. Don't ask me why. I don't know. But it's not a continuous current. It's not on all the time. It has a large interpulse interval. But it's not known as, in any books that I've looked at, and I've looked at all of them, because we used to call it a high volt, we used to call it a DC current, and they don't refer to it as a DC current anymore. But I understand what you're saying, and generally, the dispersive pad needs to be away from the area you're treating. Does the book say that it needs to be above?
Not for wound healing, I was thinking more for edema, that's just...
Yeah, I don't know, but look that up, see if it says above, because I don't know if that's true. But just to not to correct you, but just to comment on the DC current. The jury's still out. I shouldn't say jury, like I said, they used to call this just a direct current, but then they modified it and they pulsed it, so they don't really call it a DC current anymore. They call it a high pulsed
High volt pulse current.
HVPC, high volt pulse current, yeah. They used to always call it a high volt pulse galvanic current, and galvanic we refer to, faradic and galvanic were used interchangeably with an AC alternating or a DC current. And we used to always call it that, but we don't call it that anymore. So it's interesting though, because they pulse it. So, I'm not sure.
So direct current, it can pulse though.
Yes, you can pulse a direct current, you can.
All it means is that it's on...
But yes, but direct currents they also have, so you don't have the negative effects of a direct current with a high volt. You don't have the hydrochloric acid buildup underneath the electrodes like you would with a regular DC current. So they've done something with this current, and that's why they don't call it DC anymore. They just call it pulse. But don't worry about it, because that question will never come up. Okay, so polarity, we're good. Pulse duration, low pulse duration, 60 to 120, amplitude comfortable, treatment time 45 to 60. Now this dispersive is 4 to 6 inches away from the drug electrode. 4 to 6 inches, I'm sorry, I said 12. 4 to 6 inches your book says, 4 to 6 inches, okay? And I don't think it says anything about whether it needs to be distal or proximal. We just always put it proximal. I think that's just habit. So this is transdermal, this is a DC current. So this DC current, you would have to pay attention to the cathode and the anode, because there's a buildup. It's caustic, it's uncomfortable, it's noxious, it's DC. You can cause a burn with this, okay, because things that happen underneath the electrode themselves. So I said it's a 40 milliamp minute, right? 40 milliamp minute. I think I have a picture here too. All right, so here it is. You guys see this? It says here ampere or milliamps. It says time, and it has milliamp minute, or the amount of the time that the current will be on. So if I'm setting, if I want a 40 milliamp minute treatment, and I set it at 4 milliamps, it's going to take 10 minutes to complete the treatment, because 4 times 10 is 40. All right? If I had 2.5 milliamps, how long would it take to do a 40 milliamp minute treatment?
2.5 into 40, so that'd be 10, 17 and a half minutes.
You guys get that? No? Isaiah? Chris, you want to explain it?
Yeah, if it's 4 milliamps per minute in the original example, that's why it would take 10 minutes, because it's just 40 divided by 4. If you had 40 milliamp treatment at 2.5 milliamps per minute, you just divide 40 by 2.5, and that gives you how long it.
Okay, so 4 into 40 is how much? 4 into 40 is how much? 10. 2 into 40 is how much? 20. 2.5 into 40 is how much? So you'd have to do your long division, right? Can you do that? You could do that, right? Yeah. So, or you'd have a little calculator. Right? But 2.5, 40 divided by 2.5 is? 16? 17? What is it? 16? 16. Okay? So that's all you'd have to do. What if I said 3? Your intensity was 3. Isaiah, what would it be then? How much time would it take if your intensity was 3 milliamps? What would it be?
Would it be like 3 over 40?
Yep. And so what would that be?
Like 13 something?
How many minutes?
Like 13?
13? So 3 into 40 would be 13, right? 13 in a bit? Yeah, correct. See? You got it. Everybody got it? All right. All right, so here these are buffered electrodes which help with the caustic stuff that happens on the electrode, which I'll tell you about in 1 second. Yes, because under, I'm sorry, go ahead.
Just the labels on the machine, the middle one is time, and the one on the right is.
The one on the right is amplitude, the one in the middle is time, and the one on the left is the required milliamp minute treatment time. Okay? Because there's chemical response underneath the electrode, and if you buffer the electrode, it changes the chemical response. So, remember I said before, probably the only thing they may ask you is hydrocortisone, dexamethasone. What's solicitate? Anybody? Aspirin. So dexamethasone, hydrocortisone, dexameth is negative, hydrocortisone is positive, and then for analgesia, lidocaine. So on the state board, you may just see dexameth, hydrocortisone, or lidocaine. All right, dexamethasone is a negative polarity. So if you have a cathode and an anode, Jade, if I have a cathode and an anode, and I want to deliver hydrocortisone, where would I put the hydrocortisone? Under the cathode or under the anode? If I had 2 electrodes, one's a cathode, one's an anode, and I wanted to put hydrocortisone on one of the electrodes to deliver it to my lateral epicondylitis, would I choose a negative polarity, a cathode or an anode? A cathode?
That's positive.
Is a cathode positive?
Oh, wait,
An anode.
yeah.
Right? You guys agree? You choose an anode to place the medication? Yes. Yes. Now, I always give you examples, or try to give you examples of like a 1 or a 2 point question on the state board. There's 1, 2, and 3 point questions. A 1 point question would say, do you put the positive positive medication under the positive electrode or negative electrode. The 2-point question will say, do you put the positive medication under the anode or the cathode? Because they want you to know which one's positive. The 3-point question will be much more detailed, yes.
How do you determine how many milliamp minutes you need?
You don't. I'm sorry, how many milliamps you set it for?
No, how many milliamp minutes you need to treat for? How do you determine that?
You don't. That's already determined by the manufacturer.
Okay.
Yeah. There's, in fact, it's changed a little bit. They also say that you could do a 80 milliamp minute treatment, or in cases where you want the drug dispersed over a 24-hour period, you could do a 0.1 milliamp minute, a delivery of a current of 0.1 milliamps over a 24-hour period. So someone somewhere has determined that there is a specific amount of time or a specific amount of this drug that needs to be delivered in order to create this response, but you don't determine that. All right? As far as the intensity, though, you do determine. Because if I start turning up the amplitude in person, and we're going to do this, and it's going to burn. Especially if it's, depending on what electrode it's on, it's not comfortable. So a patient may say, oh, I can't take that, it's burning. And in fact, when we're going to do this with water today, and what polarity does water have? Positive and negative. Has a positive and negative. So if we're going to use like a negative electrode and place the water under the negative electrode, you're going to have little red prickly area and little burning. All right? We won't turn it up that high where you actually have a burn, but it's not going to be comfortable. Okay? So, side effects. Chemical changes underneath the electrode. So you're going to have sodium hydroxide will form under the negative electrode. All right? That causes skin irritation and burning, and that's known as an alkaline reaction. Okay? Sodium hydroxide. Underneath the positive electrode, you can have hydrochloric acid can build up. That's an acidic reaction, and that's less uncomfortable. Still uncomfortable, but it's less uncomfortable. So I place these electrodes on someone, and they start to complain to me that they really can't take even like 1 milliamp. What do I do?
Increase the size of the electrode.
Increase the size of the electrode. Thank you. Did everybody hear what he said? Increase the size of the electrode. I can guarantee you that's a question on your next test. I can guarantee you it's a question on the state board exam. Increase the size of the electrode. Okay. All right, here's that 24-hour patch. So initially the battery will activate, you apply the drug to the electrode itself, you activate the battery, you get a slow delivery of this medication over a period of 24 hours, and it's a 40 to 80 milliamp minute treatment. Okay? Much more comfortable with the patient. If you have this on a patient, and let's say you're treating that lateral epicondylitis, and you place the electrode on and they were able to take 2 milliamps, so they were able to sit there for 20 minutes. What do you tell them to do when they leave? Go play baseball? Run around the park? What? Nothing. You say try to do as little as possible because we want the drug to stay where it is. Okay? I mean, realistically, a person's going to get out and they're going to do a million things, but you want to say to them, listen, take it easy after we do this because we want that drug to stay there and we want the effects of that hydrochloric or that that lidocaine or whatever we use, dexamethasone, we want it to stay there, okay, to work on that inflammation and that pain. Okay, TENS units, these are just the units themselves, they're just for pain. So conventional or high rate TENS, these are the names of these parameters that we choose when we use a TENS unit and we treat pain. There's a conventional setting, which is high rate, low width. That talks about the gate theory. That's no different than anything we've talked about. There's an acupuncture-like TENS or a low-rate TENS. Low-rate, high-width. Release of the endorphins, our own endogenous opiates. There's brief intense, which is high-rate, high-width. Lasts for a very short period of time, and it It provides an analgesic response, so it numbs the area quickly. And then there's a burst mode, which is stimulated, the stimulation is delivered in bursts. And then we could also modulate the current with those little TENS units. Okay. So conventional TENS is based on that gate theory. Again, I'm repeating what we said a million times, but sometimes repetition is good. Frequency of 100 to 150 pulses per second and a low pulse duration of 50 to 80 milliseconds. Patients should feel a tingling and no muscle contraction. Okay? Treatment time, you use it for 20 minutes, and the pain relief as long as the stimulation is applied, the patient feels it. Feels pain, gets pain relief. Brief intense, high rate, high width. It's used to block this for the nerve, so to provide an analgesic response. Okay, the theory is that it activates the C fibers that causes a release of serotonin from the brain itself. That treatment time only lasts 15 minutes. Acupuncture, low rate, high width, can last for 4 to 5 hours. It's for chronic pain, we want a motor response. Okay? So it stimulates both the sensory and motor fibers. And burst mode TENS works more like the low rate TENS. It's more effective because when the current is delivered, it's delivered in bursts. All right, so here, look at this slide, because this is the big slide out of all of them. High rate TENS, low rate TENS, brief intense. High rate TENS, sensory response. Low rate TENS, motor response. Brief intense, we're stimulating those C fibers. You want to knock, it's going to hurt. So there's the high rate is high frequency of 150 pulses per second and a low pulse duration. We modulate the current. And how long does it last? High rate TENS, only when it's applied it lasts. Okay? So can somebody use a high rate TENS, a conventional TENS setting and put it on and leave it on for the day? Yeah. If you have a TENS unit, you could attach it and you could place it on, and you could go about your daily activities. While the TENS is on, it is doing its job. Okay, once you remove it, it stops. As opposed to low rate, which lasts for 4 to 5 hours after you remove it. Okay, so where do you place these pads when we work with just a little TENS unit? Where do you place the pads? You could place them around the pain. You could place them in the spinal cord segments. All right, so if I had a lateral epicondylitis, let's say, and you treated me with iontophoresis, and you wanted to give me a TENS unit to control the pain in that area, where would you place, what spinal cord segment would you place it on? You're not going to place it directly on the spine, but lateral to the spine. Where are you going to place it? Chris?
C6.
C6. Why?
Well, that's where the dermatome is that leads from here down
Yeah.
through here. So
Yeah. So we got dermatomes and we have myotomes that are associated with, and what if I was doing supraspinatus?
C4.
C5 and 6, right? C5 and 6.
Oh, 'cause it's, okay.
Yeah. What if I were doing triceps? Triceps? C7, C7, C8, right? C5, C6, C7, C8. We're talking about the radial nerve. Radial nerve is large, right? Yeah. Okay. That's from last semester. I'm impressed. Okay, and modulate it again. We can modulate or we could sweep. All right, we'll finish this. It's not that much. You know, most of it just, yeah. All right. Most of it, and it's really not that much left. So I will finish this. I will finish this next time, and I am going to start compression pumps and traction. Okay, so we're going to be playing with a compression pump in lab as well as a traction machine. Are you a little clearer on electricity? Okay. If you didn't read the chapters, Be honest, who didn't buy a book?
It's in the drive.
We have access to it.
Who didn't read the book? Be honest. Yeah, I know you didn't.
I was sick.
You gotta read.
I was
You-
sick and
All right,
lemon.
all right. Is it easy to read this book? No. It's not. Is it important to read this book?
So wait, let's talk about that.
Andrew?
Not going the next 9 days with this.
Isaiah?
That exam really is
Dude, we have tons of time. I don't wanna hear it.
We have a lot of time, we're supposed to do all this.
Bro, I'm gonna be gone Friday, Saturday, Sunday.
That's your wedding.
That's a new bit.
Rich? Rich, where are you? Dan, do you mind unplugging that?